So let's talk a little bit about the actual hormonal management of trans patients. And I'm going to kick this off with a brief discussion on the anatomy, physiology, and pharmacology of gender-affirming care, and then I'll try and give you a practical approach to actually getting patients onto gender-affirming hormone therapy. I will have to be brief because we don't really have a lot of time to unpack this. One thing that I want to explain before we get started is just to look at what happens to the body during puberty, and I want to make the point here that primary anatomy is determined by embryology. So this happens really prior to birth, and these are primary sexual characteristics like the genitalia. Secondary sexual characteristics develop during and following puberty under the influence of sex hormones, namely estrogen and testosterone, and to a lesser extent progesterone. The way that this works is that the hypothalamus, a gland in the brain, releases something called gonadotropin releasing hormone, GnRH. GnRH stimulates the release of two other hormones from the anterior pituitary gland. This is luteinizing hormone LH and follicle stimulating hormone FSH. These two hormones stimulate the ovaries of the testes to release either estrogen or testosterone, depending, of course, on the tissue. And estrogen and testosterone produce the development of secondary sexual characteristics. So here's just an image of how that works. Neurons that produce GnRH. GnRH acts on the pituitary, which produces LH and FSH, acting on the ovary or the testes. Now, when we look at the pharmacology of the medication that we use as part of gender-affirming care, I'm going to just list them for you briefly, and these are the medicines we'd use for assigned male at birth patients. So the first group that you see here are estrogens, and this can take the form of a conjugated equine estrogen. This is also known as Premarin, as ethinyl or estradiol. This is the formation or the formulation commonly used in combined oral contraceptives. 17-beta estradiol, this is estrofen, for example, and estradiol valerate. This can be an injection, this can be an oral tablet like Estropause, and of course this can also be found in transcutaneous estrogen like the skin patches. Then we have the progesterones, and there are synthetic progestogens like medroxyprogesterone, and there is bioidentical progesterone. And then the last group here are the antiandrogens, or the testosterone blockers. When we speak about assigned female at birth patients, we're predominantly talking just about testosterone. This is usually an injectable in the form of testosterone supinate, depotestosterone, testosterone undecanoate, this is Nebido, or Sustanon, a mixture of testosterone esters. There's also one oral preparation there that we'll talk about, Misterolone. So when we come back to this image, what I want you to understand here is that these little arrows that you see acting up here and over here on the left suggest that there are negative feedback loops. And that means that in response to a high level of either estrogen or testosterone, we will see drops in the levels of GnRH and of LH and FSH, and of course in the stimulus for the gonads to release sex hormones. So I want you to keep that concept in the back of your mind. We're going to look briefly at the effects of feminizing HRT, and I won't go through all of this. I'm sure the slides will be made available to you and you can recap them in your own time. But what I really want you to see here is that I've listed the average, everyone is different, but the average amount of time that it takes to start seeing changes, the period of time where you get maximum development of those changes, and whether the changes are reversible or not. And what you'll notice here is that the majority of the effects of feminizing HRT are reversible, with the exception of breast development, with the exception of its effects on fertility. But just about everything else that we talk about is reversible. And the second important point here is just to note that the majority of changes will really start to kick off somewhere between 3 and 6 months, but that it does take years in order to see maximal effect of those changes. The masculinizing effects are similar, but there are more irreversible effects here, and notably what I'm talking about here is the development of facial hair, potentially the loss of scalp hair, effects on fertility that are sometimes irreversible, hypertrophy or growth of the clitoral tissue, and deepening of the voice. These are all irreversible effects. You'll also notice that the irreversible effects really tend to become prominent only from about 6 months onwards. Okay, so understanding these sort of fundamental concepts in the bird's eye view, let's talk about the practical process of putting people onto HRT. The first question that I like to ask when I do this training live and in person, excuse me, is have you ever prescribed HRT for a trans patient? And if you haven't, why haven't you? And one of the answers that I get is that people are often afraid of the side effects or the risks associated with HRT. And as you can see here, I have listed several different, very serious and very worrying side effects like dizziness, depression, impotence, edema, fatigue, insomnia, nightmares, low blood pressure, hallucinations, allergic reactions, cardiac failure. These are all the side effects of atenolol, a medication that I'm sure many of the clinicians attending this workshop have prescribed before. So it really just proves to you that the understanding, or the fear rather, that we have around gender-affirming hormone therapy is maybe a little bit disproportional. Any medicine that we prescribe has side effects, is potentially very dangerous, must be used responsibly, but we don't hesitate to use medication or to prescribe it when there's a purpose for it. And as we've discussed throughout the day, myself and other speakers, certainly for trans folks, there is a need and an imperative on getting access to gender-affirming care, so it should be taken seriously. What we used to do in the good old days, especially for assigned male at birth patients, was we would put them on testosterone blockers and antiandrogen, plus oral estrogen, and sometimes a form of progesterone. The traditional recipe for assigned female at birth patients was testosterone given by an intramuscular injection. These are valid approaches that are still often used, but there are some newer and arguably better developments that we're aware of now, which I'm hoping I'll be able to share with you. So to give you an idea of my reticence and reluctance around using antiandrogens, for a long time we thought that it was necessary to use antiandrogens because we could never give people high enough levels of estrogen without giving them an unacceptably high risk of an adverse event. And predominantly when we talk about estrogen, what we're worried about here is thrombotic events or the formation of blood clots. So we had to give people an additional medication that was costly, that had a lot of side effects, and that would often oversuppress testosterone simply because we were underdosing them with estrogen. One of the most commonly used antiandrogens is spironolactone, and there's a growing body of evidence to suggest that spironolactone is not as useful as we thought. It's actually a blood pressure medication. It's a potassium-sparing diuretic because of its chemical structure and the similarities in structure between aldosterone and the androgens like testosterone. There is a strong, or a relatively strong, anti-androgenic effect that we see with spironolactone, but it's predominantly an antihypertensive. The problems that we see with this, and indeed some of the other antiandrogens, is that they can cause disruption of the hypothalamic pituitary axis. And this is because they tend to also deplete neurosteroids, which again have a very similar chemical structure, which we don't have time to get into. But just to say that these medicines are not completely innocuous. So here's just a list of side effects, and this is anecdotal information because there aren't good studies around it. A lot of the medicine is used off-label, so we don't always have good evidence on what it does in trans folk, but just some of the scary side effects people reported. Cyproterone acetate, the other commonly used antiandrogen. This is sold as Androcos, the originator. There's a couple of generics. It's not approved in the US by the FDA because of hepatotoxicity, which doesn't occur all that often, but it can be quite severe. There aren't a lot of data on the side effects that we see with cyproterone acetate. It's probably safer than spironolactone. It is certainly more expensive. And also just worth bearing in mind is that it's very, very potent, and we often use it in doses much higher than is necessary. Okay, so what I want to talk to you about really is estradiol only HRT or estradiol monotherapy. And the reason that this is exciting is because if we go back to that image that I showed you with the hypothalamic pituitary gonadal axis, you'll remember that high enough levels of estrogen or testosterone will suppress the production of GnRH, LH, and FSH. And what I'm telling you here is that if you give patients high enough doses of estradiol, you will cause suppression of testosterone production without any additional medication. And this is what we've done for many, many years with assigned female at birth patients, where we gave them testosterone, but we never needed to give them anything to block the estrogen or to antagonize estrogen, because the testosterone regulated that itself. So our challenge in doing this is to get adequate levels of estradiol, this is E2, without inordinately increasing estrone levels. Estrone is another chemical form of estrogen that is a weaker antagonist at the estrogen receptor. So it basically competes with estradiol and impairs feminization, but it's also associated through some other means that we don't fully understand with the thrombotic risk. So how do we do this? Well, we do it by bypassing the digestive tract, because the preparations of estrogen that we give to patients, especially estradiol, are only metabolized to estrone, which causes the thrombotic risk when they go through the liver. And as you know, if you take something through the digestive tract, before it reaches the systemic circulation, it goes through the portal circulation, the liver gets hold of it, metabolizes it, and in this case, turns estradiol into estrone. So in order to get high enough levels of estradiol to suppress testosterone production, we must go outside the digestive tract. In terms of doing that, we have a couple of different options. You can use transdermal. These are patches, gels, and creams. The absorption is variable between different patients. It can be impractical because often you have to wear multiple patches at a time or cover a large surface area with creams or gels, and it ends up costing on average 650 Rand a month. You can have a pellet implanted, usually in the buttock. These are compounded individually, and the nice thing being that they last 4 to 6 months, but it is a minor surgical procedure every 6 months to replace these pellets. And it also becomes difficult to adjust the dose once it's in. It's not something that you can do on the fly from 1 week to the next. And then the last option that I'll talk about is the injectable, newly available in 2019. This is estradiol valerate. It's also compounded. It can be used subcutaneously or intramuscularly. Of course, some patients are needle phobic. That makes it a little difficult. The really nice thing about the estradiol valerate is just that it's super affordable, averaging around 250 Rand a month. So when we use feminizing HRT, we are not so much looking to achieve a target estrogen level, but really to get to T suppression, testosterone suppression. As a rule of thumb, we want to get testosterone into the same range that we use for cisgender women. Labs quote various different reference ranges here. I tend to go with 0.22 to 2.90. Please note that we don't want an undetectable testosterone, the same as we see in cisgender women who have undetectable testosterone levels after menopause. It causes a variety of symptoms like fatigue, depression, exhaustion, etc. So we want low but not no testosterone. We can titrate that testosterone level depending on whether someone still desires erectile function. And these are ballpark figures, so really take them with a pinch of salt. But we aim for closer to like 1.7 in the middle of that reference range for people who want erectile function. For those who don't, we try and get it to closer to 0.5. It's very useful to measure LH and FSH for to determine if you've got gonadal testosterone suppression. And for those patients who do need additional testosterone blockade, we can do so with bicalutamide, half a tab taken twice weekly because it's got a very long half-life. And it is a safer antiandrogen because it doesn't cross the blood-brain barrier. as readily as the others. Worth noting here, just in practical terms, that the estradiol valerate is quite a thick, oily preparation, can be difficult to inject it, but you can do it as a subcutaneous injection if you have the right material to do it. We don't like to inject this into the anterolateral aspect of the thigh because the uptake is too fast. And if we do inject it correctly, then we can dose people just about once a week, and it's usually okay. Just to look at the difference between the syringes, you can see there the ideal one to use is a lower lock adapter where the needle can't pop off. We can inject this if you use the lower lock syringe with a very, very tiny small needle, a 30 gauge by 1/2 inch needle. A word on bioidentical progesterone here. We don't add this generally before TAN stage 2 because we want people to have adequate development before they do that. It does have some anti-androgenic properties. It does promote hair growth. We should only use the micronized bioidentical progesterone. There's no place for synthetic progestogens. And these are marketed as Utrogestan, available as a 100 microgram or 200 microgram capsule. Can cause some lightheadedness or some dizziness. Better to take it at night. Can also be used as a suppository to avoid first-pass metabolism and improve the efficacy. A brief overview on the masculinizing hormone therapy, and then we'll get to the sort of specifics. So testosterone should be used parenterally if you go through the digestive tract, like with Anastacia. It's not as good as an androgen. It gets inactivated in skeletal muscle, and it's got really bad effects on the cardiovascular risk. Testosterone is a potent hormone. You don't need to block estrogen at all. And often for patients who desire the cessation of monthly bleeding, you'll be able to do this just with testosterone. There are some other options that we can add in if we still struggle with monthly bleeding. So the options for the parenteral testosterone, again, gels and creams like Androgel are available. Implants can be made up, but with testosterone, there are injectable preparations that are commercially available. And that's either the short-acting depot testosterone or the longer-acting libido, or the Sustanon that we spoke about a little earlier. So here's the practical stuff. What do you do at your first visit? Just like any other consultation with any other patient, you introduce yourself, you take a full history, you do a complete examination, draw some labs, and obtain informed consent. So just to give you an idea of which laboratory tests and what special investigations and how to target your clinical examination, the risk factors that we're looking for in our trans populations are risk factors for coronary artery disease, for deep vein thrombosis or pulmonary embolism, embolic stroke, liver disease, pituitary adenoma, uncontrolled hypertension, uncontrolled diabetes, breast or uterine cancer, because these are often hormone sensitive, and erythrocytosis. In terms of a family history, we're looking for a family history of cancer, especially of organs like the breast or the colon or ovaries or prostate. We're looking for a family history of diabetes or heart disease or hypertension or liver disease to tell you that this patient will need closer care and monitoring. The laboratory tests that we like to do, and of course this is in an ideal setting, so baseline lab tests for assigned female at birth or assigned male at birth patients, a full blood count, a kidney function panel, liver function panel, a fasting glucose, a fasting lipogram, and of course, sexual health screenings like hepatitis testing and HIV testing. One thing that we do need to talk about before initiating hormone therapy is just the effects on fertility. It can render patients infertile. The infertility might be irreversible. A lot of patients who go on hormone therapy have never had children, so we don't know that they have baseline fertility. Having said which, HRT is not a replacement or a substitute for contraception, so people can still impregnate or become impregnated if they're using HRT, so one should counsel patients around that. How do you initiate HRT? For an assigned male at birth patient, you'd want to start off with either estradiol skin patches. This is something like Estradot, 100 micrograms, done or changed twice weekly. So I put every 72 hours, but it's basically every 3 to 4 days that you have to change patches. or a starting dose on the injectable of 0.3 moles done either subcutaneously or intramuscularly per week, or oral estradiol at 2 to 4 milligrams. So that's estrofem tablets, 1 or 2 of them. Ideally, these should be used sublingually, but they can be used per us. Sublingual use of the medication is very time consuming, but it does also bypass that first pass metabolism that we spoke about. And of course, that's done daily. You'll notice there that I haven't listed any of the antiandrogens. For assigned female at birth patients, I usually start them on depot testosterone because it's the most accessible, the most affordable, and the easiest to adjust the dose at 0.5 moles, preferentially by subcutaneous injection once a week. I want to review my patients ideally after they've completed a minimum of 4 therapy cycles. So this either means 4 weeks on injections or 8 patch changes or 30 days on oral treatment. And I like to look at their hormone levels here. If I can choose only 1 or 2 tests to do in an assigned female at birth patient, I'll want to do my total and my free testosterone. In an assigned male at birth patient, I'll want to do my LH and my FSH, but ideally we'd want to look at all of those and additionally the estradiol for an assigned male at birth patient. Remember that the laboratory testing is really only there to support and guide clinical decision making. It is your patient's experience and your clinical examination that should really be guiding the specific management for your patient. So remember to treat the patient and not the results. When you do review a patient, you want to look for a response, side effects, and consider increasing the dose if that's something that your patient wants to do, and if you've determined clinically that it's safe to do so. I usually tinker with doses on not less than a monthly basis. For patients on injectable estradiol valerate, we'll consider sometimes splitting the dose if necessary. Some patients metabolize it faster than others, and they get a dip towards the end of the weekly cycle. After that initial review, you will, once you've got your patient, or let me say after you've titrated the dose to a point where you're satisfied, you can then follow up your patients a little bit less frequently. You can do a 6 or 12 monthly review there with a full physical and laboratory testing, the same as the original panel, with the glucose and the cholesterol and the kidney functions and the liver functions. And that is the process of initiating HRT in a nutshell. What I haven't given you here is information about the antiandrogens because I think that they shouldn't be used unless it's absolutely necessary. If you are going to use them, I'd suggest bicalutamide. I already spoke about using that as a half a tablet twice weekly. If you have to use cyproterone acetate, you should be looking at dosing with a quarter of a tablet. At the most a quarter of a tablet, if not an eighth of a tablet. It's very difficult to break or cut the tablet into eighths. So often a quarter tablet every 2 days will do. And just to give you perspective, it's a 50 milligram tablet, so a quarter tablet is 12.5 milligram. Spironolactone, we usually start at 25 milligrams. Don't go too heavy on the antiandrogens. Use as little as you need to get away with it, and rather try where it's possible to put patients on the parental options. Some of the other preparations that we still use in other settings, especially in the public sector, are preparations like Premarin, where we'll start patients on either 0.625 or 1.25 milligrams a day and build them upwards from there. Please remember that, of course, combined oral contraceptives with ethanol, estradiol in are not a good fit for hormone replacement therapy because the ethanol estradiol carries an unacceptably high thrombotic risk, and also because the majority of these are packaged together with synthetic progestogens. So I'm sure that there will be some resources made available to you, but I hope that you've got an idea and an overview as to how to get started in terms of prescribing HRT, and I hope it's taken a little bit out of the fear out of that for you. So thank you very much.